what about the microscopic disease? Part two of this operation, the hot chemotherapy. What is that? So Hipec, as we abbreviate it, uses both heat and chemotherapy to kill these cells. Not only does the heat directly kind of heat up and kill the cells, but chemotherapy works better at these temperatures, and so it is a synergistic effect. When I give patients chemotherapy through their veins, it does have some effect in the peritoneum, but it is limited to get in there because this is kind of like a big cave or cavity where these tumors hang out, and doesn't have as good of blood supply or penetrance as if I gave chemotherapy directly to that area. So when you give Hipec, it pumps it inside that cave and kills the tumors directly like that. It also means the inverse is true, is that because we have that barrier there, less of this chemotherapy is absorbed into a patient's circulation, and so we can give higher doses in the abdomen than we would ever give through the veins. So Hipec is kind of unique in that is that we are able to do this regional treatment with high dose chemo and heat in a 90-minute span. We have certain drugs that we use for Hipec, the most common being mitomycin C, cisplatin, or oxaliplatin. But more are needed. I think these are old drugs and they're effective, but if we can get more targeted drugs, more effective drugs, I think that would help more patients too, and certainly research is being done in these areas. My overall summary of who we look at for CRS Hipec: low volume disease, good biology, resectable, that's potentially curative. Versus the other flip side of the coin is high volume, bad biology, unresectable disease. We kind of have to consider other ways to treat you because CRS Hipec is probably going to hurt those patients more than help them.